Heya and welcome back to Synapse. This is Ritika and today we'll talk about nephrotic syndrome. Before I start talking about nephrotic syndrome, I would like to tell you there is a video on nephritic syndrome on Synapse. Do watch it for better learning with comparison. Diving into today's topic, nephrotic syndrome is the complex of four main features. So you see massive proteinuria, hypoalbuminemia, generalized edema, and hyperlipidemia and lipiduria. Whatever be the actual cause of nephrotic syndrome, the main pathogenesis remains the same. It starts with increased permeability of the glomerular capillary membrane, which leads to increased amount of protein loss at the glomerulus, which leads to massive proteinuria of more than 3.5 grams of protein loss per day. With long-standing massive proteinuria, obviously the amount of proteins present in the plasma is going to reduce, which is majorly albumin. So this leads to hypoalbuminemia. Talking about the generalized edema, the hypoalbuminemia itself is contributing to edema, but there is also a series of phenomena that happens which aggravates this edema, and that is because of hypoalbuminemia, there's going to be hypovolemia. That is, the amount of blood volume decreases, which decreases the renal blood flow, because of which there is a stimulation of renin release. Renin activates the renin-angiotensin-aldosterone system, which increases the sodium and water retention, which aggravates the edema. Well, the genesis of hyperlipidemia is not very direct. Well, it could be understood that hypoalbuminemia somewhere stimulates the lipoprotein synthesis. There could also be a mechanism that due to massive proteinuria, there could be loss of the inhibitory proteins. And there could also be impairment of the peripheral breakdown of lipoproteins. Now, all these factors contribute to hyperlipidemia. Now that there is increased permeability at the glomerulus, this lipid may leak out into the urine, leading to lipiduria. We have four main causes of nephrotic syndrome. They are minimal change disease, focal and segmental glomerulosclerosis, membranous nephropathy, and membranoproliferative glomerulonephritis. Minimal change disease is the most common cause of nephrotic syndrome in children. And it could be idiopathic or could be associated with drug usage such as NSAIDs, or it may be associated with Hodgkin's lymphoma, upper respiratory tract infection, or atopy. The main pathology involved in minimal change disease is that there is podocyte damage. That is, there is effacement of the food processes of the podocytes. And according to the recent research, we have found that this damage is due to suppressor T cell activity. In minimal change disease, the kidney looks normal, grossly and under light microscope. And that is why it is called the minimal change disease. But under electron microscope, you can see the effaced podocytes, and also you can see that the proximal tubular cells are lipid laden. And this can be given the term lipoid nephrosis. In a few conditions, this lipoid nephrosis could be apparent even under light microscope. And immunofluorescence shows that there are no immune complexes, and that is why it can also be called as nil deposit disease. In minimal change disease, we observe massive proteinuria, and this proteinuria is selective type of proteinuria where low molecular weight proteins are mainly lost, especially albumin. So this leads to hypoalbuminemia, and additionally there is hyperlipidemia. The treatment of this condition is done with steroid usage. The next cause of nephrotic syndrome is focal segmental glomerulosclerosis. Well, this is the most common cause of nephrotic syndrome in adults. It is called focal because only some of the glomeruli is actually involved. And it's called segmental because only a part of the glomeruli is affected. This could be of primary etiology or could be secondary to HIV infection, heroin abuse, or sickle cell anemia. Unlike that seen in the minimal change disease, focal segmental glomerulosclerosis is shows non-selective proteinuria. That is, along with albumin, other proteins such as immunoglobulins, etc. are also lost in urine. Here too, we see that there is effacement of the podocytes, which is the main pathology. Microscopically, you see that there is hyaline changes seen in the affected part of the glomeruli. And this hyaline change is because of deposition of proteins, lipids, immunoglobulins such as IgM and complement proteins. There is also increased mesangial matrix and narrowed capillary lumina. There exists a very severe variant of focal segmental glomerulosclerosis called as a collapsing glomerulopathy, where there is porocyte hyperplasia and there is collapse of the glomerular tufts. And this is most commonly seen in association with HIV infection. The next cause of nephrotic syndrome is membranous nephropathy, which is a common cause of nephrotic syndrome in elderly. Well, it could be of primary etiology or could be secondary to drugs such as NSAIDs, penicillamine, infections such as hepatitis, malaria, autoimmune disorders such as SLE, or could be secondary to few cancers. The pathogenesis involved in the primary membranous nephropathy is that there are autoantibodies to certain antigens, which is most commonly phospholipase A2 receptors, which are present on the porocytes. This mediates the porocyte damage. The experimental model of membranous nephropathy is called the Hayman nephritis, where the antibodies are induced against Megalin antigen present on the porocytes. Here too we see non-selective proteinuria and there is no inflammation. Well, if there is no inflammation and there are no inflammatory cells, then what is causing the damage to the glomeruli? Well, the damage is caused by the membrane attack complex, which is composed of the complement proteins, which directly damages the mesangial cells and the porocytes. Diffuse thickening of capillary wall is also evident in membranous nephropathy. This is because of the deposition of the immune complexes. These immune complexes are deposited subepithelially, that is, on the outer aspect of the glomerular basement membrane. With time, the basement membrane grows around the deposits, giving it a spike in doom pattern. Membranous nephropathy does not respond well to corticosteroid therapy. The last cause of nephrotic syndrome we're going to talk about is membranoproliferative glomerulonephritis, which is characterized by massive proteinuria, hematuria, and hypertension may be present. The MPGN can be of type 1 or type 2. In type 1, the pathogenesis is because it's basically the circulating immune complexes gets deposited and is usually following hepatitis B or C antigenemia or following SLE. While MPGN type 2, also called as a dense deposit disease, is due to autoantibodies called the C3 nephritic factor. And this autoantibody is against C3 convertase enzyme. This autoantibody stabilizes the C3 convertase enzyme, because of which there is continuous stimulation of the C3 complement protein, thus leading to continuous stimulation of the alternate pathway. And this with time is going to lead to hypocomplementemia. Microscopically, it is characterized by the presence of proliferation of mesangial and the endothelial cells, and the basement membrane is thickened, and there is a double contour which gives it a tram track appearance. And this double contour is because of splitting of the basement membrane, and this splitting is due to extension of the processes of mesangial and the inflammatory cells, and also deposition of the mesangial matrix. And here I'm done talking about the nephrotic syndrome. I hope this video helped you. If it did, like the video and share. If you haven't yet subscribed, please do subscribe.